Good afternoon. My name is Michael. I'm a student FNP nurse. And your name is Tatiana?
Yes,
Yeah. Can I address you by Tatiana?
correct.
All right, thank you. I'm going to be performing the cardiac respiratory assessment on you today. Is that going to be okay? All right, I'm going to go wash my hands and then we'll just begin after that. All right, first I'm going to assess the posterior skin of your chest. Can I have you sit right here, please, and look this way? So right now I'm going to be assessing for any skin changes, looking for any cyanosis or pallor. And then I'm going to be assessing for moisture, texture, edema, or turgor, which would indicate any problems with poor hydration or poor circulation. And then finally I'll be assessing for any lesions, scars, any ecchymotic areas, any nevi, and the patient's back looks good. Next, I'm going to be assessing the patient for any symptoms of respiratory distress and looking for the patient's using accessory muscles to breathe. Is there any nasal flaring? Is she in a tripod position with her arms at her knees bent over? And is there any retractions, visible retractions, or is any cyanosis? And the patient is not having any trouble breathing. Next, I'm going to inspect the chest for symmetry and looking for any deformity, such as a viral chest or any symptoms of scoliosis. And the chest looks well formed. Next, I'm going to assess the posterior chest wall for symmetry. I'm going to assess the spine. I'm going to palpate the spine, palpate the scapulas, the shoulders, and also going to be assessing for musculoskeletal development. I'm checking to see if there's any tenderness to the spine area. Or any deformities to the spine. Is there any pain? Are you feeling any pain?
No.
Alright, can you bring your arms back just like that? Thank you very much. Assess the scapula. Is there any pain?
No.
Again, I'm looking for any structural deformities. There is a tenderness. Excuse me. Next, I'm going to inspect the patient's shoulders. Inspecting the clavicle, acromions right here. Is there any pain to that area?
No.
I'll assess this side. Any pains at all to this area?
No.
And next, inspect for musculoskeletal development. Inner bicep muscles look intact. Tricep, can you move your arm down, please? Thank you. Tricep is developed, muscle, they all look proportional and well formed. Any pain at all?
No.
Tricep and bicep. Thank you for that. Next, I'm going to assess the patient's respiratory rate. And to see how she's breathing, I'm looking for excursions. I'm checking the depth. I'm checking the pattern of her breathing and the rhythm. And I'm also looking for chest symmetry. And I'm also trying to rule off if the patient is wheezing or short of breath. Are you okay?
Mm-hmm.
No problems breathing?
No.
Next, we're going to go over and I'm going to check the posterior chest wall and assess for symmetry. And I'm going to do that by palpating the lower portion of her chest wall. And I'm going to place my thumbs pointed directly to her spine. And I'm going to have her breathe in. Take a deep breath, please. You take another deep breath. And I was assessing to see if my thumbs equally separated, which would indicate symmetry, which was the result. Next, I'm gonna palpate for fremitus, and I'm gonna have the patient say 99.
99.
And can you say 1, 2, 3?
1, 2, 3.
And that's what I got fremitus on both sides equally. Again, if I was hearing increased symptoms of fremitus, this would indicate possible pneumonia, and a decrease in fremitus would possibly indicate a pleural infusion. Next, we're going to move on into, I'm going to percuss the patient's back, and I'm looking for areas of dullness. Should be resonance throughout her back. And everything was appropriate in that assessment. Next, I'm going to assess for diaphragm excursion. And to do this, I'm going to percuss, starting at the top of the lung and work my way down. And then I'm going to have the patient take a deep breath and exhale. And she's going to hold her breath. And I will be able to assess an area of dullness, which would be the top part of the diaphragm. So, can I get you to take a deep breath and then exhale, then hold that breath? Okay, and that area of dullness, you can breathe now. You can let that out. Now I need you to take a deep breath and hold it. And then I'm assessing the resonance until we hear another area of dullness. And then that is your diaphragm excursion, which on average is 3 to 5 centimeters. Next, I'm going to auscultate the patient's lungs posteriorly. Deep breath. Deep breath in and out. Deep breath in and out. Deep breath in and out. All lung sounds were clear. Next, I'm going to auscultate the lateral portions of her lungs. Can I get you to release your arm? Thank you. Deep breath. And next, I'm gonna assess the middle right anterior lobe. Please. All right, I received all clear sounds through her bilateral lung fields, the lateral lung fields, and the right middle lobe anteriorly. Excuse me. Next, I'm going to assess the patients for what's the name of it? Echophony, and bronchophony, and I just forgot the names. I apologize. All right, so what I'm going to do is have the patient say the letter E, and the E should come out fuzzled and muffled. And if it doesn't, if it comes out with a clear sound of A, then that's a positive sign of agaphony. Sorry about that. Can I get you to say E?
E, 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 E.
That's a clear sound of E. So next, I'm gonna assess for bronchophony, and I'll have the patient. Let me see. I'll listen to it right here. Gonna have the patient say 99.
99, 99, 99, 99, 99, 99.
And I was able to hear a fuzzy 99 sound, which is an indication of there's no consolidation in there. If I was able to hear a clear 99, then that would give some concern that the patient does have possible pneumonia. And finally, I'm going to do the whisper pectorally. I'm going to ask the patient to whisper 99. And I wasn't able to hear that. So again, if I was able to hear that clearly, then again, that would indicate consolidation and possible pneumonia. And then finally, I'm going to assess the patient's posterior chest for costovertebral area. And we're going to be assessing for any inflammation to the patient's kidney. So I'm just going to palpate here, and then you tell me if this is painful or not. Any pain to the area?
No.
All right. So that's a negative on the CVA. Next, I'm going to move the assessment over to the anterior chest wall. And again, we're going to start off with inspecting the skin to the patient's chest. And I'm looking for areas of discoloration, cyanosis, pallor, nova.